Um, Good evening, everyone. My name is Janet, and today I will be taking us through autoimmune hepatitis, a case study. So we're going to be going through the case of EM, an 8-year-old boy from Murang'a who was admitted 2.5 months ago. He's accompanied by his mother. He presented with hotness of body for 3 days, confusion for 2 days, and diarrhea for 2 days. This patient, of note, this is a patient known to be living with autoimmune hepatitis and portal hypertension for the last 1 year. He was diagnosed at KNH. He is compliant to the following medication: spironolactone, furosemide, propranolol, and omeprazole. So for the history of presenting illness, the patient was last well 2.5 months ago. The mother noticed that her son was hot to touch. This was in the evening. She gave him some paracetamol, but it persisted throughout the night, but she reports no night sweats. The next morning, she reports that her son seemed confused and that he would repeat the same 3 words over and over again whenever she asked him a question, and she did not understand what he was saying as he tried to converse with the mother. There was no associated loss of consciousness, no convulsion, but the mother reports that he seemed very tired. On that same day, he had countless episodes of loose stool, which was non-bloody, non-foul smelling, with no visible mucus, and it was yellow-brown in color. There was no associated abdominal pain or vomiting. He was taken to a peripheral facility, and then from there, he was referred to KNH. A few days post-admission, he developed significant abdominal swelling, scrotal swelling, lower limb swelling, up to the mid-thigh level, and hand swelling. Days later, he developed yellowness of the eyes. There was no associated itching of the skin. His urine was either clear or yellowish. There was no dark urine. There is no history of eating or drinking at a new location. The mother is not aware of anybody else that has had diarrheal symptoms, either in the family or at the boys' school. They buy bottled water for drinking at home, but he occasionally drinks the tap water at his school. So on admission, the following investigations were done. A full blood count was done. He had a HB of 8.7 grams per DL, an MCV of 93.9, platelet count of 17 times 10 to the power of 9, white blood cells of 12.94. For the, these are the coagulation tests, which would tell us the secretory function of the liver. The APTT was 50.5 seconds, which is elevated. The prothrombin time was 13.5 seconds, which is normal. The INR was 1.13, which is normal as well. The AST on admission, was 90.8, which is elevated. The ALP was 204.7, which is elevated. The ALT was 81.9, also elevated. The total bilirubin was 47.9, which is elevated, and the direct bilirubin was 40.16, which is 84% of the total bilirubin. His albumin was 18.7. Of note, there was no malaria parasite found on the blood smear. His blood gas analysis had a pH of 7.319, bicarbonate of 19.9 millimole per liter, and partial pressure of carbon dioxide at 5.3. An anti-HCV2 test was done, which was non-reactive. HIV antigen antibody non-reactive. Hepatitis B surface antigen was also non-reactive. The analysis of acidic fluid showed no pus cells, and there was no growth on the culture. So the medication that he has received since being admitted: ceftazidime, prednisolone, lactulose, omeprazole, ibuprofen, furosemide, spironolactone, vitamin K, ursodeoxycholic acid, and coconut oil. He has had acetic tapping 3 times since he got to KNH. Each time, around 1.5 liters of fluid was removed. The first and second tapping were 2 days apart, then the third one a week later. An MRCP was done a month ago, and we're still waiting for the results. He has been booked for a pigtail catheter since there's no more fluid on tapping despite the massive ascites. He is no longer confused. The fever has resolved. The diarrhea has also resolved. The lower limb swelling and the hand swelling have also resolved. He still has yellowness of the eyes, abdominal swelling, and scrotal swelling. The most recent labs, we have them here. His full blood count, HB of 11.3, MCV 92.4, platelet of 146, white blood cells of 12.2, APTT of 38.84 seconds, prothrombin time of 14.25 seconds, INR was 1.19, the AST 31.7, ALP 141.9, AST 28.2, total bilirubin of 54.18, direct bilirubin of 36.16, the albumin was 27.7. For his past medical history, this is his third admission. All of his admissions have been related to the chronic liver disease. The first admission, he presented with fever and hepatosplenomegaly. The second admission, it was for the esophageal-gastroduodenoscopy and a biopsy. The findings of the biopsy were consistent with liver cirrhosis. For the ANC, the mother attended 4 clinics. Triple serology was non-reactive. She has no complaints antenatally, intrapartum, or postpartum. She had no complications, sorry. For the birth history, he was born at term via cesarean section, secondary to a previous scar. He cried immediately. There was no resuscitation, no NBU stay. He was discharged home after 3 days. For the immunization history, the mother reports that he's fully vaccinated according to the KP schedule, but she did not bring the book, so I cannot verify that. Nutritional history, he was breastfed for the first time at around 2 hours after being born, exclusively breastfed for 6 months. For the 24-hour recall, the mother says that in the morning, he usually has tea and bread for breakfast, porridge mid-morning, rice and beans or peas for lunch, ugali and greens with occasional meat for supper. For his family social history, he's the 4th born in a family with 3 living children. A sister from the pregnancy before him, there was intrapartum fetal death. The family lives together, the parents with 3 children. The mother, a 46-year-old, stays at home. The father, a businessman. I think he's 48 years old. I should have added that. The mother does not recall the exact age for the developmental milestones, but she said that he has been growing well prior to the illness, and his performance in school has dropped in the last 1 year since he got sick. For his review of systems, the systems that have not been discussed in the HPI, his respiratory one unremarkable. There was no cough, no chest pain, no difficulty in breathing or in the respiratory in review. No palpitations, no chest pain, no dyspnea. There was no muscle aches, no joint pain. For the physical exam, on general exam, on examination, he's in fair general condition. He was sitting in bed, eating his breakfast. He's oriented in time, space, and person. He has scleral jaundice, conjunctival pallor, no clubbing, no cyanosis, no lower limb edema. For the vitals, SpO2, 98 on room air. His temperature was 36.2, heart rate of 83 beats per minute, respiratory rate of 26. For his abdominal examination, on inspection, there was a massive abdominal distension with flank fullness. The umbilicus is flat, but the abdomen moves with respiration, and there was no caput medusae. On palpation, the abdomen is tense. I was unable to ballot for the kidneys, and I was unable to pick out any organomegaly. For the percussion, there was a positive shifting dullness and a positive fluid thrill. Auscultation, 4 bowel sounds heard in 1 minute. For his respiratory exam, on inspection, respiratory rate of 26 breaths per minute. He had no visible scars, bilaterally symmetrical chest with no masses. Palpation, there was a central trachea, equal chest expansion on both sides. For percussion, there was an equal percussion note on both sides across all lung fields. Auscultation, there was good bilateral air entry. There was no wheeze, no crackles. Cardiovascular system, peripheral pulses were felt. At the radial pulse, there was good volume, regular pulse at a rate of 83 beats per minute. On inspection, there was a normoactive precordium, no scars, no masses. Palpation, the apex beat at the fifth intercostal space, mid-clavicular line. There was no heave, no tapping, no palpable thrills. Auscultation, S1 and S2 had no added sounds, no murmurs. So in summary, this is EM, an 8-year-old boy known to be living with autoimmune hepatitis and portal hypertension for the last 1 year, admitted 2.5 months ago, who presented with a 3-day history of fever, 2-day history of confusion, and a 2-day history of diarrhea. Then later developed jaundice, ascites, testicular hydrocele, lower limb edema, and hand edema. There was no associated pruritus, no pale stool, no dark urine. On examination, scleral jaundice and conjunctival pallor were present. There was a positive shifting dullness and positive fluid thrill on abdominal exam. So the diagnosis is acute decompensation of chronic liver disease secondary to the gastroenteritis and hepatic encephalopathy. My differentials would be a spontaneous bacterial peritonitis, but that is ruled out by the fact that the acidic fluid had no pus cells and no growth on culture. A viral hepatitis, which I guess has also been ruled out by the tests that were done, the hepatitis C and hepatitis B. Sepsis is also one of my differentials, so is malaria, because we know that the negative blood slide does not necessarily mean there's no malaria. So the plan as of now was to, as of the time of clacking, was to get the pigtail catheter to manage the ascites, to continue with the ongoing medications, and to monitor the vitals and await the MRCP results. Thank you.
Natra, you can start your presentation and then we can have the Q&A session after.
Good evening, everyone. Assalamu alaikum. My name is Natra Kalargulet, level 5 UN, and I'll be presenting the autoimmune hepatitis for tonight. So we're going to go through autoimmune hepatitis through the following. So we're going to define and classify. We're going to look at the pathogenesis, investigations, management, complications, and we're going to look at what we call overlap syndromes. Now, autoimmune hepatitis is a chronic inflammatory liver disease of unknown etiology, and it is characterized by immune-mediated hepatocyte destruction. So this is when the immune system essentially loses tolerance and starts attacking the hepatocytes. So you're going to find like it's not an objective when like there's not an objective test. So you're going to have, let's say maybe on histology, you're going to find an interface hepatitis, which you're going to see more of. And then you'll have the elevated serum IgGs, presence of circulatory autoantibodies. Then you're going to exclude any other cause of chronic hepatitis, and you're going to see their responsiveness to immunosuppressive therapy. Now to classify or autoimmune hepatitis, you can have the type 1 and the type 2, and then you can on type 1, you're going to have your autoantibodies being mostly your ANA and anti-smooth muscle antibodies. The age mostly is for adolescent girls, and your clinical presentation will be as chronic liver disease and sex of more of female compared to male. And then your histology, you're going to have a common presentation of cirrhosis. And then on type 1, you're going to find that they are more responsive to your prednisolone. So you'll be able to wean off in type 1 compared to type 2. So in type 2, you're going to have your anti-liver kidney M1 and then anti-LC1. Age is mostly exclusive to pediatrics only. And then clinical presentation, they're going to present more like an acute liver failure. And then histology, you're going to have necrosis and cell drop. And when it comes to immunosuppression, you're more likely going to need a lifelong medication. And then there's a type 3, mostly not really common, but when you have a liver transplant, let's say, and then the transplant was maybe a reason not autoimmune hepatitis, and with that new liver transplant, then you get an autoimmune hepatitis, and now that will be your type 3. So a de novo autoimmune hepatitis on a liver transplant. So between the two types, type 2 is more severe, is more likely to progress to end-stage liver disease, and you are less likely to take it off medication. Now on pathogenesis, these patients will find they are genetically susceptible, so you're going to have your HLA, DR3, DR4, and DR7. So like self-presenting antigens abnormality to the CD4 T cells. The HLA DR3 more likely on like younger onsets, more likely to have a severe disease and poor remission. And HLA DR4 in milder disease with better response. Now, pathogenesis is mostly a genetic combined with environmental trigger. So you're going to have your environmental triggers. Let's say maybe the patient gets a viral infection, most likely CMV or the Epstein-Barr virus. Then that is going to trigger an event, and then there's going to be a molecular mimicry where the immune system mistakes the liver cells for the virus, and then going to have the disease. So there's also the drugs, hepatotoxicity, and so the immune system, in the presence of any of this, gets confused and starts attacking the liver cells. And then there's the immune effectors, the CD4 plus Th cells activate the B cells together with the CD8. And then there's the loss of the regulatory T cells, which now is a key mechanism in autoimmune hepatitis. So the CD8 together with the CTLs directly kill hepatocytes, and then the B cells will likely show the ANA, SMA, your autoantibodies. So in histology, you're going to find the key clue of interface hepatitis. That's when the plasma cells, the lymphocytes invade the portal tracts. And then on histology, you see on this picture showing the normal hepatic lobule with a portal tract, your portal vein, artery, and the duct. And then on autoimmune hepatitis, you're going to realize an infiltration. So you find lymphocytes, plasma cells actually infiltrating the portal tract and going extending through the hepatic lobule. So when you find this on histology, then you're going to have this as a key feature in autoimmune hepatitis, still not specific for autoimmune hepatitis only. So clinical presentation, autoimmune hepatitis is master in disguise. So you're going to have patient presenting with all these symptoms, but then your number suspect will be viruses, maybe hepatitis A, B, and C. So you have to rule out every other cause of chronic or acute liver hepatitis before you make your diagnosis. So the insidious, about 50% patients present with fatigue, anorexia, they have weight loss, arthralgia, amenorrhea, and gradual onset of jaundice. Usually takes weeks to burn, so that's why it is often misdiagnosed as viral hepatitis. And you'll find sometimes patients with acute hepatitis, autoimmune hepatitis being treated as a viral hepatitis, and now that will lead to disease progressing as fast as possible, and then leading to cirrhosis, a point of no return at that point. So acute hepatitis about 25%. So here you're going to have an abrupt jaundice, right upper quadrant pain, patient present with malaise, fever. Same thing, it will mimic acute viral hepatitis. And at this point, antibodies may be low in the early stages. Then the acute liver hepatitis. So you're going to find your INR of more than 1.5 together with encephalopathy and a massive transaminases rise, your LTNSTs. Then this is more common in type 2 and with younger children. It has a high mortality rate as well. So your systemic symptoms, fatigue as most common, arthralgia, migratory arthritis, anorexia, nausea, right upper quadrant pain, and in adolescent girls, amenorrhea, and then fever, which is more common in acute. Then in hepatic, you're going to have your hepatic signs, jaundice, dark urine, pale stools, hepatomegaly, splenomegaly. So you see, all these symptoms are not like, there's no specific symptom that will direct you towards autoimmune hepatitis. So that's when you find a patient presenting in such, it's really significant that you do your test as fast as possible, rule out every other cause of hepatitis, then you can rule in this. So on exam, it is really important to check the Kayser-Fleischer rings, the KF rings on slit lamp, to exclude the Wilson disease as well. Because sometimes you might think you can't rule out you can rule out every cause of hepatitis and then treat autoimmune hepatitis, but maybe the disease is Wilson disease, which actually presents similar way of autoimmune hepatitis. So you also rule out Wilson disease in the management. So investigations, what do we do? So apart from your CBC, we like your baseline investigations, the more specific one for autoimmune, we do our LFTs. So you find your transaminases, AST and ALT being really high, which will indicate parenchymal injury. Your ILP GGT actually will be high, especially when we have an overlap, meaning not only is our hepatocyte cells injured, but also we have the biliary tree involvement. So when you have both your hepatocytes cells injured as well as your biliary tree involvement, then we say we have an overlap, meaning we have a autoimmune sclerosing cholangitis or primary sclerosing cholangitis together with an autoimmune hepatitis. So when we have both transaminases high and GGT high, then you're going to also in your investigations, you're going to do MRCP, that's the MRI of the liver. Then in most cases, when the biliary tree is involved, then you're going to have, or you're going to see beading or narrowing of the ducts. So IgGs also, so it's an autoimmune, so probably they will be raised. Albumin, you're going to do your INR and bilirubins, which all of them will be deranged. And then in our autoantibodies, they will be present, but then the titers are also very important. So the presence of the autoantibodies and the titers of the autoantibodies. So in type 1, we're going to have our ANA and our asthma. In type 2, anti-LKM, anti-LC, and then we can have our anti-SLA, LP, and type 1 as well. Oh, so before that, to also exclude Wilson, you can do your 24-hour urine copper, your slit lamp, which we said will show your KF ring, and seroplasmin as well. Now, there's this diagnostic criteria mostly used in adults, because in pediatrics, when you really have a suspicion of autoimmune hepatitis, you don't really follow this criteria as strictly as we follow in adults. So if you have, if you suspect autoimmune hepatitis in pediatrics, you start treatment as early as possible, regardless of your score. So this is the score, these are the parameters, the findings, and then you score up to 15. More than 7, you definitely autoimmune hepatitis. If you score 6, probable, and then less than 5, unlikely. Then in pediatrics, we say the disease is severe compared to adults, and then the disease actually progresses way faster compared to adults. So in management, number one thing, our goals are number one, to suppress the inflammation. and we do that by suppressing the immune system. And then we're going to aim at preventing cirrhosis, and then we're going to maintain remission with minimal toxicity, and then we try to preserve growth and development. So our first line is we can use the guide of the SGAN or ASLD. So we're going to have our steroid prednisolone. We can do 1 to 2 milligram per kg per day, a maximum dose of 60 milligram per day, and then we're going to try and taper it off over 4 to 8 weeks. So 2.5 to 5 milligram per day of maintenance in the maintenance period. And then we use steroid together with azathioprine, and we use azathioprine in the around 2nd to 4th week of starting prednisolone. And our main reason why we don't start azathioprine together with prednisolone is remember, your liver is injured. So our hepatocytes are injured, and azathioprine being metabolized in the liver is more likely, number one, to cause liver hepatotoxic. And the other thing is if we have our transaminases still high, we won't be able to actually know if this is a cause of the autoimmune hepatitis progression or azathioprine. So we do prednisolone in the first 2 to 4 weeks. We try to work up the liver, and then we start azathioprine being helped by our TPMT. So you check TPMT. If TPMT is absent, then you don't start azathioprine. If TPMT is low, then you can start with a low dose of azathioprine. If TPMT is normal, then you start the standard dose of azathioprine. And then you have your second lines. So if you fail with the first line, you go to second line. MMF. You can start with mycophenolate, mofetil, or you can use budesonide, tacrolimus, and cyclosporin, and rituximab, your B-cell depleters. So acute hepatitis in acute liver failure and overlap syndrome. So pediatric autoimmune liver failure, we define it when you say we have a pediatric acute liver failure is when we have an INR of more than 1.5 together with a hepatic encephalopathy, or we can have an INR of more than 2.0 without encephalopathy. So how do we manage when we have this? So number one, you refer. There is a patient who needs a liver transplant. And at the same time, we can start an IV methylprednisolone 2 mg per kg per day for around 5 to 7 days. And then the diagnostic criteria for a patient who might need a liver transplant is when you have INR of more than 4 or INR of more than 2, together with a bilirubin of more than 235 micromole per liter in an age of less than 2 years. Or you can have 3 of number 1, non-hepatitis A or B infection, INR of more than 3.5, and a bilirubin of more than 300 micromole per liter. Now, when we have autoimmune hepatitis together with primary sclerosing cholangitis overlap, then number one, these are prevalence in more than 50% of patients' cases. So if you make a diagnosis of autoimmune hepatitis, you also rule out autoimmune sclerosing cholangitis. And then I said we can use our MRCP. So definition, autoimmune hepatitis features together with the biliary changes on MRCP, the beading strictures, meaning you have narrowing of the ducts. Key investigation, MRCP. Associations, you also rule out inflammatory bowel disease. This in around 50% or more of patients who have, let's say, ulcerative colitis, or more likely compared to Crohn's. If you have any symptoms of inflammatory bowel disease, you suspect autoimmune sclerosing cholangitis. And then the treatment, the same, immunosuppression together with UDCA. Then prognosis, when now you have this overlap, the hepatocyte injury together with biliary tree involvement, you're going to have a worse prognosis compared to when you have a pure autoimmune hepatitis. Complications and prognosis. So the disease complication is cirrhosis. You can get portal hypertension, acute liver failure. Also, you're going to have that low risk versus viral cirrhosis. So patients with this have a higher risk of developing cirrhosis, osteoporosis, and pathological fractures. And now, that is the treatment complications also. So you're using steroids. So there's that Cushingoid symptoms, growth retardation, hypertension, hypercalcemia, osteoporosis. Azathioprine also, myelosuppression, hepatotoxicity, MMF, having teratogenicity, GI side effects. So when we come to the prognosis, 10-year survival rate of, you're going to have more than 90% of patients, and autoimmune hepatitis is a treatable disease, but not curable. So 90% of them will be treated, and 10-year survival. Biochemistry remission, about 80 to 90% of your LFTs will come back to normal. Relapse off treatment, around 50 to 80%. Transplant, those who will need transplant, less than 10%, and recurrence post-treatment, about 25%. So treatment withdrawal, so attempt only after 2 or more years of biochemical remission with normal biopsy of the liver, meaning there's no any infiltrates of the lymphocytes or plasma cells in the liver lobule. So type 1, only 20 to 40% maintain sustained remission of treatment. Type 2 is actually rare to achieve remission. So most probably they require lifelong therapy. In adolescents, they have high risk for relapses. So because of non-adherence, hormonal changes, so there's that structured transition essential. And after first relapse, there's reinstate plus maintain. If they maintain for more than 2 years, further years before reattempting withdrawal. So this is just summary of what we've just discussed. So how do you approach a child with high transaminases plus autoantibodies? So a child is suspecting to have autoimmune hepatitis. So number one thing is you're going to take a detailed history, look at the symptoms, duration of the symptoms. Is there any drug exposure? Family history of liver or autoimmune diseases. Look at any symptoms of inflammatory bowel diseases. Are you going to do your investigations? So after you do your baseline, CBC, and any other that you might want to check, so you'll go specific for LFTs, IgG, your autoantibodies, coagulation profile, do viral serology, and rule out Wilson screen. Then you go do liver biopsy, probably to confirm if there any interface. So confirm histology with stage of fibrosis, and this is essential for diagnosis in most cases, though not really specific for autoimmune hepatitis only. So also after history, you do your examination, you do your images, ultrasound, liver ultrasound first line, then MRCP if you suspect a biliary disease, and then you make your score and start treating patient or refer patient. And that was it. Thank you.
Thank you so much, Natra and Janet. Now I'd like to invite Dr. Levin to give us his insights, and then after I'll give room for questions and inputs, if any. Welcome, Doc.
All right, thank you very much. I had to ask myself, is it a medical student who is making this presentation? Is it a resident, or is it even a fellow who's making this presentation? So I'm hoping the slides are original, because it's a fantastic presentation. I know that a lot of it is may sound slightly beyond fifth year medical student level. But I just love the presentation. Now, I think the key things for you to guys remember. The case presentation. I think the case presentation is a child known to have chronic liver disease, autoimmune liver disease came in, and I think you said the presentation was there was a bit of confusion, right? And the child
Yes.
came in. So when the child is in that particular state, what do you think was going on? Probably a bit of hepatic encephalopathy, right?
Yes.
That confusion, okay? So
Yeah.
that's something that probably, and the child improved afterwards. That's one. Now, secondly, I think for us, the key things to remember when you go out there as doctors is that not every child with jaundice is hepatitis. Yes, most times it's going to be hepatitis. Usually it's viral hepatitis, hepatitis A, and most times hepatitis, especially hepatitis A, will resolve if there's persistence of symptoms. And we had a child like that, I think today in the clinic as well, 3-month history of persistent jaundice, I think 9 or 10 or 10-year-old. So at that point in time, now you start suspecting that there's something else going on, because viral hepatitis, especially hepatitis A, will not persist for that long. So when you see that, now you start thinking there is something else going on. And in your mind, you must have some other differentials. Okay, drug-induced liver disease is one, and autoimmune liver disease is the other one. And of course, Wilson's disease has also been mentioned, so that's a good thing. So how do you make a diagnosis of autoimmune liver disease? I think the criteria were well specified in the presentation, very well done. For me, the clue in is because we are in a resource-constrained environment. When we ask for liver function tests, who can tell me? I think the people who are there in the clinic today, who can tell me what the LFTs might show? That would be a clue that this might be autoimmune liver disease. Who is willing to be brave? Before you ask for your autoimmune serology, the total albumin, total protein and albumin levels. Normally, the albumin, the range is between 35 and 50 or 45. If the albumin is low and the protein is very high, so that tells us that the gamma globulin fraction, the globulin fraction is high. And that's one sign. It's not a definitive sign. It's a clue that there's something going on and this might be autoimmune hepatitis. The second thing is we call it autoimmune hepatitis or autoimmune liver disease. And I think it was very well stated that hepatitis is necrosis of the liver parenchyma, and so your transaminases are going to be high. So if your AST, ALT are high, that tells you there is a hepatitis going on. If your globulin fraction is high, it's usually higher than the albumin, it tells you that this might be autoimmune. You may or may not be able to manage it at that point in time, but at least you can have a tentative diagnosis. You can call to find out what else needs to be done, and or you can refer. So my suggestion, so that's the important thing. Okay, so look at the LFTs. Remember, you should know how to interpret LFTs. It's a question that we could ask in your OSCEs as well. We'll bring some LFTs and we ask you to interpret your liver function test. Again, I know I'm sidetracking a little bit because of this OSCE thing has just come up. When the OSCE question is there and you're supposed to interpret results, remember that if it's normal, it's important to state normal. Don't only think that abnormal is what needs to be reported. Even normal needs to. For example, if the total protein is within normal range, then you write there total protein normal, AST elevated. Okay, so make sure that you say these things. So LFT's interpretation may be a possible question you ask you, so you should remember that. Just like it could be UECs, it could be full hemogram. Okay, it could be an ascitic tap for that matter. So for me, you should remember the LFT interpretation. Think beyond if the child, and especially that age group, it's persistent, the jaundice is not clearing, and this is unlikely to be viral hepatitis. So think of your other differential diagnosis. All right. A final, again, very well done. Final question. So what does what is the unofficial version of anti-LKM antibody? You know that the official one is liver kidney microsomal. Who can tell me? Who was there in the clinic with me today? You guys don't know?
It's Laving, K, and then
There you are. Ah, yeah, that's it. Okay, good. Was very well done. I know this is a bit of a complicated, and this is more. I think I might ask who was presenting. Is it Natra? Who did the presentation?
Yes, Doc, you're right.
Natra. I might ask you to give the same talk to my residents. I think you gave such a good presentation.
Thank you,
Okay,
thank you.
thank you, thank you.
I'll now open the floor for anyone who has a question, an inquiry. Please feel free to unmute or type in the chat box.
Either it was very well understood or it was too complicated. Liver transplants done. Yes, indeed, not in our country, but other countries do have this option of liver transplants. We follow quite a few patients post liver transplant. We saw one today in the clinic as well. So yes, it's a possibility, and after transplant, a lot of the children do quite well. Excellent question, Huri. Yes. So ideally, we should provide, but sometimes, the reference ranges may not be given, unfortunately. So need to your hemogram, your HB, your platelets, white cell count, those UECs especially critical. Those are important. What's a normal random blood sugar? Okay, BGAs. Okay, you should know the normals because you may or may not get the reference values. LFTs, it would be mean for me to give an LFTs without giving the normal range. And if I, for example, did it, it's not because I'm mean, it's because I probably forgot, okay? But it's good to know the norm reference values for most, the common lab tests. Okay, good. Thanks. Time for Isha almost. Thank you very much. I suggest next time I'm happy to do this, but let's pick a topic which is less complicated. Okay, I know the presentation is very nice, but let's do something that is probably a little more relevant and try to make things with interactive with the audience as well. But we should do that next time. All right, thank you very much.